Good evening and welcome, dear colleagues, students, fellows from wherever you are. And today's session is on echocardiography, something which is very important and which continues to evolve in critical care. And this is going to be part two of our session. Dr. Punit Khanna, who is additional professor, Department of Critical Care and Anesthesiology, All India Institute of Medical Sciences, will be taking the session. He had taken a very nice session a year ago on echocardiography. That was part one. This is going to be part two, and this is all going to be new with a small, brief recap of what we had in the part one. So that part one is there in our channel. Many of you have seen that, and those of you who have not seen that can refer to that because there's going to be no real overlap. Just a brief recap will be there. So Dr. Punit Khanna is a very uh, accomplished person in this field. He has written books on echocardiography, focus, ultrasound in the critical care area, and he has around 100 publications. And really is very good at all this echocardiography and the use of sonography in the ICU. So it'll be great learning for all of you. So with that, I hand it over to you, Dr. Khanna, sir.
Okay, sir. So we will, myself, Punit, and this will be like a second part of the previous video that we had done. There will be a little recap. Last time it was a sensitization, and this time it will be like echocardiography in the ICU from evolution to revolution. So what evolved is now a revolution. Every intensivist uses echocardiography. And without wasting much time, we straight away go ahead. My apologies. Again, I think we are stuck. Yeah. It's moving now, I think.
Yeah.
Just give me a little second. Okay. So interpretation of echo measurements in the ICU. So again, like previously, I will re-emphasize, we are not replacing the cardiologist. As much of the work has been developed in the cardiology outpatient population, where heart rate, rhythm, contractility is consistent between the studies. Majority of the measurements are load dependent and very significantly in the critically ill. The scenario changes in the critically ill. So the trend is more important. What trend? Trend of worsening or improving is more important than the absolute value of each measurement. Dr. Tapesh, I am having some issues with this thing. I don't know.
Sir, you can try sharing again or move from another point. There are different ways of moving the slide. Just try different ways. Just moving
I am trying different way. Yeah, this is there. This is there
from
now.
the keyboard. Sometimes that helps.
Yeah. That is there. Clinical scenarios requiring echo. So commonly, hemodynamic instability in a patient, left-right ventricular failure, acute coronary syndrome and its complications, hypovolemia, valvular pathologies, cardiac tamponade, embolism, and infective endocarditis. So there are many scenarios which require echocardiography. This is an old slide. Previous recap starts now. Advantage and disadvantages of echocardiography in the ICU. It's non-invasive. It's a real-time monitoring. It requires less time, and it is often possible offline. Point to remember: images in images in transthoracic echocardiography are inverted as opposed to transesophageal. Basics: transducer, phased array probe. Optimal transducer transthoracic echo is a phased array, typically frequency between 1 to 5 hertz. Basics: align, tilt, rotate. You have to get the view. Have an optimal depth. You won't get the proper picture if you have inadequate depth or excessive depth. How to prepare and position the patient? Set the probe cardiac, supine, turn the patient to the left side. For the parasternal and the apical view, abduct the patient's left arm, which will open the intercostal spaces. Marker to the right side of the screen. In all other modes, it will be on the left side of the screen. Position ideally left lateral decubitus. Problem, frequently this position is not possible in the ICU. Basics, 3 windows, 5 views. 3 windows are apical, parasternal, subcostal. For apical, left 4th to 5th intercostal space. Parasternal, left 4th, 2nd to 4th intercostal space. Subcostal, just below the xiphisternum. Views, plaques, parasternal long axis, parasternal short axis, apical 4 chambers, subcostal 4 chambers, subcostal IVC. This is all a recap. This is a photo depicting parasternal long axis, apical and subcostal views. So parasternal long axis, to achieve plaques, echo probe is placed in the left 2nd intercostal space with the marker facing towards the right side. Then the probe is gently swept between the 2nd and the 4th intercostal space to achieve the long axis view. Just see how the phased array probe is placed and the rays are cutting the heart. The visibility will be right ventricle, left ventricle, mitral valve, left atrium, atrial valve, and left ventricular outflow tract. So how it appears in an echo, and now we fill the colors. Right ventricle, left atrium, aortic valve, and LVOT. Parasternal long axis view. So what do we see? Right ventricle, we can see the size and the function. Left ventricle, we can see the size and the function. Ascending aorta, we can see the size, aortic valves. We can see for the motion, opening and calcification. We can see the mitral valve. We can see their motion, opening and calcification. We can comment on the pericardium, pericardial fluid. Short axis, to achieve the short axis view, parasternal short axis view, the probe is rotated clockwise. Where it was placed in plaques to the left, so that the marker of the probe is now directed towards the left shoulder of the patient. Parasternal short axis can be obtained at 3 places. Parasternal short axis can be placed at 3 places. The aortic valve level. At the aortic valve level, you can see the right atrium, the left atrium, the aortic valve, outflow tract, pulmonary valve, and the pulmonary artery. At the aortic valve level, now what we can comment upon the aortic valve level, we can see the cusp opening and the calcification. We can see the tricuspid valve. We can see the pulmonic valve. We can see the right atrium. However, it is better appreciated in a 4-chamber view. We can also comment upon the left atrium. At the mitral valve level, you see the right ventricle, you see the mitral valve, and you see the left ventricle. Just see how we are rotating our probe. This is how the parasternal short axis appears at the mitral valve level. Right ventricle, interventricular septum, left ventricle, the mitral valve. Parasternal short axis, mitral valve level. What you can comment upon? You can comment upon the right ventricular size and function. You can comment upon the interventricular septum, its shape in systole and its shape in diastole. You can comment upon the left ventricular size and function. You can comment upon the calcification and the opening of the mitral valve. You can comment upon the pericardium, whether it has pericardial fluid or not. Third view, at parasternal short axis, papillary muscle level, right ventricle, left ventricle, you can see the papillary muscles quite visible in the screen. Here we fill up right ventricular, left ventricle, and you can see the papillary muscles over here. Parasternal short axis, papillary muscles level. What you can comment upon is right ventricle size and function, interventricular septum, left ventricular size and function, inferior wall thickening and motion, anterior wall thickening and motion. This is important. Now coming to the apical 4-chamber view. So the apical 4-chamber view, you can see this is the most common view to visualize the heart. The probe is just placed lateral to the apex in the left 4th to 5th intercostal space and adjusted to get the view. Lateral to the apex in the left 4th to 5th intercostal space. The probe should be shifted left or right, gently orient the right interventricular septum parallel to the screen to get a true 4-chamber view. Probe is placed lateral to the apex in the left, fourth or fifth intercostal space. Fine. What you can see, right ventricle, right atrium, left atrium, mitral valve and tricuspid valve. So here it is, your apical four chamber view, right ventricle, left ventricular, valves, atrium and so what you can comment upon is right ventricle, left ventricle size and function, left atrium size, right atrium size, mitral valve, tricuspid valve, motion and regurgitation. Five chamber, a slight modification of the four chamber view gives you the five chamber view. The probe is just lateral to the apex, left, fifth or sixth intercostal space with anterior angulation. What is the difference? Basically, you can see the aortic wall in the long axis of the left ventricular and pulmonary veins are no longer visible. Apical five chamber, that's it. Main thing is aortic valve, motion and regurgitation. Subcostal four chamber. To obtain this view, the probe is placed in the subcostal area while the marker is facing towards the left and it tilted upwards to look at the heart. See the probe, marker towards the left side, probe tilting upwards, placed in the subcostal area. You see the right ventricle, right atrium, left atrium, tricuspid valve and liver. You can appreciate the diaphragm as well. So here it is, your subcostal four chamber view, RVLV, RALA. Subcostal four chamber view, you can comment upon left ventricular, right ventricular size and function. You can comment upon the pericardial fluid. You can comment upon the mitral valve, motion and regurgitation. What's the importance of a subcostal IVC? So the IVC draining into the right atrium, you can visualize the liver. Subcostal IVC. This is all a recap from my previous webinar. So IVC used for volume status, where you have to measure it. I have pointed out at the level of the hepatic vein. You can visualize the hepatic vein, see the IVC draining into the right atrium. Fine. So this volume status based upon the IVC diameter, normal IVC diameter is 1.5 to 2.5 centimeter. If the IVC diameter is less than 1 centimeter, it's a severe volume depletion. If it is less than 1.5, you can say volume depletion. If it is greater than 2.5, it is volume overload. IVC diameter with respiratory variations, during inspiration it collapses. If it is with positive pressure ventilation, normovolumic or hypervolumic patient, it remains constant. In hypovolumic patient, it shows variation. Okay, the collapsibility index or the Cavel index, spontaneously breathing patient. I am again emphasizing upon the fact, spontaneously breathing patient, IVC collapses to more than 50% with inspiration or sniffing. So the Cavel index is maximum expiratory minus minimal inspiratory upon maximum expiratory diameter. If the collapse is greater than 50%, patient is volume responsive. In adults, following correlation is present between the central venous pressure, IVC diameter and respiration. A size of less than 2.1 centimeter collapsing greater than 50% during sniff is equal to the right atrial pressure between 0 to 5 millimeter of Hg. If the size is greater than 2.1 centimeter and the collapse occurring of greater than 50% during sniff, the right atrial pressure may vary between 5 to 10. If a size is greater than 2.1 and collapse is less than 50% during sniff, a right atrial pressure between 10 to 20 millimeter of mercury is present. Distensibility and variability index. Now, again, I will emphasize upon some mechanically ventilated patient with no respiratory effort and a tidal volume of greater than 8 ml per kg. So, distensibility index is D max minus D minimum upon D minimum. If the distensibility index is less than 80%, it is not volume responsive. The change in IVC diameter, say like maximum diameter minus minimum diameter upon mean diameter into 100. If the delta IVC is greater than 12%, it is fluid responsive. The slides till now were just a recap. Now from here on, I have included the intricacies of various systolic functions and diastolic dysfunctions of the left ventricle and the right ventricle. And I have given an attempt to look at certain pathologies and what are our echo findings in those pathologies. Fine. Echo modes, everybody is aware of 2D mode, two-dimensional cross-sectional view. If it reflects, it's bone, it's white. Low reflectivity, muscle. It's gray. No reflection, it's water, it's black. M mode, it is for detecting and recording rapid movements. ECG or respiratory pressure waveforms are traced alongside. Chamber dimensions, fractional shortening, and ejection fractions are calculated in M mode. So what are the Doppler modes? Doppler modes are color flow Doppler, pulse wave Doppler, continuous wave Doppler, tissue Doppler, and a duplex scan. To recapitulate, color flow Doppler, pulse wave Doppler, continuous Doppler, tissue Doppler, and a duplex scan. Now we will see how they are used. So color flow Doppler imaging, here is an example. Pulse wave Doppler. So what is a pulse wave Doppler? Our transducer transmits short ultrasound pulses at regular intervals. After transmitting the pulse, the transducer then acts as a receiver until the next pulse is sent. So the duration between these two pulses is called a pulse repetition period, PRP. Fine. The PRP is determined by the depth of the sample gate. Higher the depth, higher the PRP, and lower the pulse repetition frequency. So we have to remember two things over here, PRP and PRF. Higher the depth, higher the PRP, and lower the pulse repetition frequencies. Basically, PRF is equal to 1 upon PRP. So this is how a pulse wave Doppler looks like. Fine. Continuous wave Doppler. Continuous wave Doppler splits the crystals on the transducer into two sets for transmission and receiving echoes. As continuous wave Doppler receives the echo signal continuously, all the flow signals along the beam path will be received and interrogated, leading to a range ambiguity. What is a masking effect? Where a high velocity signal masks the low velocity signals. So this is how a continuous wave Doppler looks like. Fine. Tissue Doppler. A pulse wave Doppler measuring myocardial movements and its velocity. So myocardial motion, low velocity with high amplitude. Ultrasonographic filters only the low velocity and high amplitude waves to prevent interference from the blood, which is high velocity. At times, motion artifacts are prone to error with respiratory motion of the chest wall. These are prone to give an angle error. This is how a tissue Doppler looks like. So, heart dimensions. Basically, we will be focusing on the dimensions of the heart now. What can happen to the RV? RV can be dilated. It can be acute or chronic. LV can be dilated, but it is almost always chronic. Both can get dilated, mostly chronic failure. Atrial dilatation occurs due to chronic pressure overload or volume overload. Hypertrophy, RV hypertrophy or LV hypertrophy usually occurs due to chronic pressure overload. RV dilation can be acute chronic, LV dilatation chronic, biventricular chronic, atrial dilatation chronic, pressure or volume, hypertrophy chronic. So when we are assessing LV function, so systole, diastole, global and regional. This is how we go ahead with the LV function. Systole, diastole, global and regional. The systolic function. So let's have a look at the myocardial fibers in the left ventricle. There are three types of fibers: subendocardial, mid-myocardial, and subepicardial. The subendocardial fibers are placed obliquely, and contraction of these oblique fibers cause shortening and twisting. Mid-myocardial fibers are placed circumferentially, and contraction of these circumferential fibers, they cause myocardial thickening and reduction in the ventricular diameter. And contractile function can be classified as it may be normal, it may be hypokinetic, it may be akinetic, or it may be dyskinetic. So you can see in the video going on alongside hypokinetic, akinetic, and dyskinetic. This is again how to assess the left ventricular systolic function. Commonest is eyeballing, then are your standard measurement of dimensions. Then at M mode, you can see the EPSS, longitudinal shortening, fractional area change, ejection fraction. You can place your tissue Doppler and you can do the strain measurement with speckle tracking. So let us keep it simple. Systolic function, linear mode, M mode, EPSS, MAPC, fractional shortening. We'll come to the full forms and everything in detail. 2D measurement, we can see the fractional area change and the ejection fraction. With Doppler management, we can see the dP by dt and S velocity. This is how you go ahead with a global systolic functioning and how you assess a left ventricle systolic function. And what are the indices for left ventricle systolic functions? The dimensions. Then they are linear measurements, fractional shortening. Then they are area measurements, fractional area change. Then they are volume calculations, ejection fractions. There are various methods. Method of disc, method of quinons, area length, 3D volume. Then you can look at the mitral valve motion with MAPC. You can use the spectral Doppler, rate of pressure rise, dP by dt. You can look at the myocardial performance index. You can look at the velocity circumferential shortening. You can look at stroke volume upon cardiac output. While using a tissue Doppler, you can go ahead with systolic mitral annular velocity, strain and strain rate. These are the various LV systolic indices. Eyeballing, what are we looking for? Inward movement of the endocardium, thickening of the myocardium, longitudinal motion of the mitral valve annulus, reduced motion of the anterior mitral valve leaflet in the plaques, anterior mitral valve leaflet. It should come within 8 millimeter of the septal valve in the plaques view in systole. Normal motion is less than 8 millimeter. Moderately reduced is 8 to 18. Severely reduced is greater than 18. We can look at the geometry of the left ventricle. We can look at the size. We can comment upon any aneurysms. So one by one. First, let's take fractional shortening. Linear measurements. It estimates the left ventricular systolic function using the linear measurements of left ventricular internal diameter at the end of diastole and end systole. Fine. The disadvantages are it only assesses the mid and basal segments. And it's a poor reflection of global LV function in right ventricular motion abnormalities or an abnormal chamber shape. Again, fractional shortening estimates left ventricular systolic function, uses linear measurements, interval diameter at end diastole and end systole. Fine. This is how you do fractional shortening, left ventricular end diastolic, left ventricular end systolic upon diastolic into 100. Basically, your ejection fraction is twice into fractional shortening. If it is between 25 to 40%, it's normal. The fractional shortening, mild dysfunction, 20 to 25, 15 to 20 moderate dysfunction, and less than 15 is severe dysfunction. Ejection fraction is twice into fractional shortening. So here we are talking normal fractional shortening is say like 25 to 40, 20 to 25 is mild dysfunction, 15 to 20 is moderate, and less than 50 is severe dysfunction. Fractional shortening and diastolic minus end systolic upon end diastolic. Fine. This is how it is shows 4.5 minus 3.5 at the end, 3.1 at the end systole. Now coming, that was a linear measurement. Now we are coming into the area measurements, the ventricular volumes. The left ventricle has relatively symmetric geometry. Mathematic models using 2D imaging and M mode measurements calculate the ventricular volume in systole and diastole. And you can use LV is a little ellipse with an equal short axis and long axis twice the short axis. It has got a uniform wall motion. The fractional area change. Again, left ventricle systolic function is estimated using these area changes during diastole and systole. And endocardium is traced and at the end of diastole and systole. So the fractional area change, say like LVD area minus LVS area upon LVD area into 100. Normal fractional area change is between 45 to 80. And in males, it is 56 to 62%. In females, 59 to 65%. If the fractional area change is greater than 80%, say you can say it's like a hypovolemia, low SVR, and what you can say is maybe due to mitral regurgitation. If the fractional area change is less than 20%, it reflects an LV failure. These are the left systolic standard 2D measurements. The left cavity diameter is 4.2 to 59 centimeters in men, 3.9 to 5.3 in women. Septal and posterior wall thickness 0.6 to 1 in men, 0.6 to 0.9 in women. What we are now looking at is mitral annular velocity, referred to as S dash. So it's basically tissue Doppler imaging at the mitral wall annulus. S dash has its limitations when the annulus is calcified in right ventricular wall motion abnormality, and if there is a poor Doppler alignment. However, it estimates global ejection fraction pretty well. It's not a surrogate measure of contractility. So normal values of S dash greater than 8 centimeters per second, less than 5 centimeter estimates an ejection fraction of less than 50%. So, sorry. Then coming to EPSS, as we had told earlier. EPSS is E-point septal separation. It is very quick, but some people call it as a poor, I have mentioned dirty, is estimation of the left ventricular ejection fraction. It depends upon the free movement of the mitral valve. In short axis view, place the M mode cursor through the tip of the mitral valve, and the distance between the leaflet tip and the septum is the E-point septal separation. It is depicted over here. Parasternal long axis, M mode, EA, the difference between the septum and the E. If EPSS is less than 7 millimeter, it is normal. If it is greater than 10 millimeter, it might be suggestive of congestive heart failure. There are pitfalls and inaccuracies seen in EPSS, E-point septal separations. In right ventricular wall motion abnormalities, in aortic regurgitation when it pushes the jet, mitral stenosis, movement of the leaflet is restricted. So the EPSS is pretty inaccurate over here. So we have seen fractional area change. It is the area measurements. We have seen fractional shortening, which is first is the eyeballing, then is the linear measurement, fractional shortening, then is the area measurement, then it is fractional area change when mitral annular wall velocity, then it is the EPSS. And now coming to the MAPC. MAPC is basically mitral annual plane systolic excursion. So longitudinal shortening, MAPC, you need a apical four-chamber view. The highest and the lowest point of the M mode in a sinusoid wave are measured, having put the cursor along the mitral ring. You can see it very clearly in the slide, pointing with a pink pointer. MAPC of greater than 13 millimeter is normal. So what is MAPC? MAPC is similar to TAPC. M mode at the lateral mitral valve annulus. It only evaluates the longitudinal motion. It has got a high temporal resolution. Its limitation is by the angle dependency. Its displacement of the mitral valve plane in the long axis, it has been attributed to account for the 60% of the stroke volume. Now, we have already discussed the normal volumes. Pitfall is it does not differentiate between the global LV dysfunction from the regional valve motion abnormality. Whether it is global LVD or RWMA, it is not able to differentiate between the two. So MAPC, EPSS, S-, FAC, and FSEF. Okay. Now we are coming to the fractional area change. We have discussed it. Ejection fraction. Okay, ji. Ejection fraction again. You can see the end diastolic volume and systolic in an apical 4-chamber view. So L left ventricular end diastolic minus end systolic upon end diastolic volume into 100. This is your EF. If your patient is in a hyperdynamic state or hyperdynamic circulation, ejection fraction can be there of 60%. Normally it is 50 to 70. We take a consideration of midpoint as 60. Mild dysfunction 40 to 50%. Moderate 30 to 40%. Severe dysfunction we can comment upon less than 30%. However, this carries its own pitfalls. Left ventricular ejection can significantly be overestimated. The systolic function in case of hypovolemia and mitral regurgitation. There are softwares available which we can use to detect endocardial motion, thus giving continuous ejection fraction and stroke volume. So hypovolemia, mitral regurgitation can overestimate the systolic function and can give wrong values of your ejection fraction. This is modified Simpson's method. Divide the ventricles into 20 discs, measures and sums up the volume of each disc at the end diastolic volume and the end systolic volume. Endocardial border can be traced. It is useful if LV is distorted or there is regional wall motion abnormality. So EF is equal to SV upon end diastolic volume. So stroke volume, end diastolic volume minus end systolic volume. This is how the modified Simpson works. Now we have automated ejection fractions. These are calculated on the software-based programs. If they are semi-automated, they use the speckle tracking techniques. And the ROI is specified by placing specific points at mitral annulus and the apex. Endocardial border is automatically detected. You can manually edit the endocardial border also. Left ventricular volume in each frame is calculated by Simpson's method of Dix, and volume of curve over a cardiac cycle is calculated. We even have 3D volumetric analysis. You can easily judge out global systolic functions by semi-automatic method. 3D uses full volume loop. This is QLab Philips technology, and diastolic volume and end systolic volumes are estimated. Identify the end diastolic frame, align it in the axis. Red and green lines through the LV apex of 2-chamber and 4-chamber. Identify the middle of the interventricular septum in the blue pane using the yellow arrows. As the reference point, repeat the procedure for the end systolic. So you have to identify the end diastole frame. You have to identify the end systole frame. You have to align them. You have to place their markers. And eventually it will automatically calculate it. Tissue Doppler. Tissue Doppler. The normal systolic velocity, the S wave velocity we are talking over here, is measured at the lateral ring side. Below 8 centimeter, there is systolic depression. Below 3 centimeter, a severe systolic depression. We will discuss this in detail. S wave. S wave is basically a mitral, S dash is basically mitral annular velocity. Tissue Doppler imaging at the mitral wall annulus. It estimates the global ejection fraction. It's not a surrogate measure of contractility. Fine. And I think this we have discussed earlier as well. We can go a little ahead. Myocardial strain. This is a new slide. Prerequisite for measuring the myocardial strain are you should have an appropriate depth and your entire left ventricle should be visible. There should be no apical foreshortening. It should have a good endocardial definition. Heart rate with less than 10% variation and frame rate between 70 to 100 frames per second, and you should avoid any cautery being used. There are different types of strains, say like globular longitudinal strain and a segmental strain. The global longitudinal strain, basically longitudinal fractional shortening. It is the average of a segmental strain. Normal value is -16 to -22. Less negative means less worsening of the function. Segmental strain can tell you about the regional wall motion abnormality. It is software dependent. Then coming to global longitudinal peak systolic strain. It assesses the global systolic function. You can obtain it from the 2D in all the 6 walls and 3 views. Global longitudinal velocities varies. The software varies with different vendors, but the average is between -16 to -20. If the GLS is less than -16, it is abnormal, and it signifies left systolic function abnormality. Why do you want to measure the strain when you have fractional shortening? The strain is more sensitive to detect systolic dysfunction compared to ejection fraction. It is able to detect abnormalities before ejection fraction decreases. It describes subclinical diseases and cardiac function that cannot be expressed by conventional echocardiography. This is a very important slide. What are the load dependent and independent indices of ventricular function? So leave aside load dependent. Let's come to the load independent indices. End systolic elastance, preload recruitable stroke work, preload adjusted maximal power, and then the strain rate. What is the issue with load independent indices? Except for strain rate, no other can be used clinically. So we will focus on strain rate. This is just, we'll brush through end systolic elastance. Most of the load is independent of the index of left ventricular contractility. Pressure volume loops are created by various preload conditions using cable occlusion. And you calculate the slope line joining the end systolic points. No normative value as it varies with the size of the ventricle. These are the normal LV dimensions and volumes. These are the LV dilatations, mild, moderate, severe reference values in females and male. Coming to the LV thickness. LV septal wall thickness, SWT, and posterior wall thickness, PWT. So it's like, and diastole, excluding the papillary muscles. Normally it is less than 12 millimeter. And if it's an hypertrophy, it is greater than 12 millimeter. LV mass, total weight of the myocardium, myocardial volume into the specific density of the cardiac muscle. Remodeling, concentric hypertrophy, the normal geometry, and the eccentric hypertrophy. This is how the left ventricular mass index and relative wall thickness varies. dP by dt, spectral Doppler, rate of intraventricular pressure during systole can be estimated. Less preload dependent, measurement of the time taken dt for time to increase from 1 millisecond to 3 milliseconds. You can calculate the dp as 32, which is 4 into 3 square. Divide 32 with the time taken in 1 second. It is not useful with MR, TR, or any RWMA. Myocardial performance index. It is independent of arterial blood pressure, heart rate, ventricular geometry, AV regurgitation, and afterload. It may manifest as an increase in ICT, IRT, decrease in ET, resulting in an MPI of greater than 0.5. These are the new things: circumferential fiber shortening. It reflects the velocity of the ventricular circumference shortening of LV minor axis over a period of time. Stroke volume. Left ventricular outflow tract. It's an indirect method of global LV systolic function. Limitation. Cardiac output is not left ventricular ejection fraction, as two will have different values depending upon the disease state. Take for example MR, increase ejection fraction. Hypovolemia, decrease cardiac output. So what we can say is, what will happen if there is a dynamic LVO2 obstruction, which may be precipitated by hypovolemia and adrenergic stimulation. Importance is that reflex increase in vasopressor dose in these patients can cause a catastrophe. So cardiac output, stroke volume into heart rate. So dynamic LVO2 obstruction. How does it occur? The combination of a high flow in a narrow LVO2 generates a Venturi effect, which results in a systolic anterior motion, partially obstructing the LVO2. leading to the reduced cardiac output. Systolic interior motion can cause mitral regurgitation. Mid-ventricular obstruction, the mid portion of the left ventricle is almost obliterated during mid or end systole, while the apex is still ejecting. This is how we have a dynamic LVOT obstruction. This is the summary. Evaluation of the global systolic function. I have brushed through it, but you need to go through it slide by slide. Again, what I have done is to sensitize you. It's what are the various systolic indices, how do you measure them, what are their normal values, what are their abnormal values. Fine. So most of the existing left ventricular systolic function indices are load dependent. Strain imaging is only the clinically feasible technique that will help us in understanding the load independently. Early detection of left ventricular systolic function will help us in decision making and management of many cardiac diseases. The systole is over. Diastole. Diastolic dysfunction is the inability of the ventricle to fill to its normal end diastolic volume without an inappropriate increase in the end diastolic pressure. कब होता है ये? When does it happen? Elderly age, diabetic patient, metabolic syndrome, hypertensive patient, hypertrophy, aortic stenosis, restrictive heart disease. So diastolic dysfunction can be normal. It can be due to impaired LV relaxation. If there is impaired left ventricular relaxation, there is reduced early diastolic filling. If there is it's a pseudo normal LV filling, abnormal relaxation, restrictive left ventricular filling, advanced reduction in compliance. This everybody knows. I am not going to go through it. What are the various phases of diastole? Isovolumetric relaxation, then early rapid ventricular filling, mesodiastolic diastolic phase or diastasis, then the atrial contraction, E wave, A wave. Echocardiographic assessment of the diastolic dysfunction is based on the interpretation of a combination of echo and Doppler measurements. No single echo parameters provides a definitive or a summary of measures of the ventricular pressure volume relationship during diastole. If any parameters are abnormal, only they're reflected as an isolated change in either in relaxation or compliance. So they are affected by interaction between the changes of left ventricular relaxation, compliance, left atrial pressure, left atrial contractility, and further complicated by rhythm and loading conditions. So to assess diastolic function, you have to have an interpretation of both echo and Doppler measurements. The things to be measured to grade diastolic dysfunction: E by A ratio, E by E dash, LA volume index, TR jet velocity, and other things to complement these parameters: IVRT, DT, pulmonary venous flow velocities. We'll discuss all these things with all the full forms. Okay, LV diastolic dysfunction, pulse wave Doppler assessment of the transmitral flow. When the pulse wave is placed across the mitral valve, E and A waves, E wave represents the early diastolic filling, and A wave represents the atrial contribution to the left ventricular preload. E wave, A wave. There is a period of diastasis between E wave and A wave, with the envelope thus obtained isovolumic relaxation time, IVRT. E wave, A wave, IVRT. E wave and A wave velocities can be measured as a ratio as well. The normal E wave velocity is 0.8 plus minus 2 and A wave velocity is 0.5 plus minus 2. Again, going back, diastolic dysfunction, phases of diastole, use of both echo and Doppler, E by A, E by E, LA, volume index, TR jet velocity, IVRT, DT, and pulmonary flow. E wave represents diastolic filling, A waves the atrial contribution to the preload, diastasis between E and A waves, isovolumic relaxation time, velocity, and the normal values. Now we proceed ahead. How do we do it? pulse wave assessment of the transmitral flow. Here we measure and how it appears. Fine. So the parameters of interest are peak velocity, peak wave, E wave deceleration time, A wave peak velocity, and E by A ratio. A peak velocity and E by A ratio. So this is the assessment of the transmitral flow. Normal diastolic dysfunction. So E by A ratio is less than 1.5, mild is less than 0.75, sage to moderate less than 0.5, EA greater than 1.5 severe, and then we will classify it further. But what is the pitfall? There is an L wave during diastasis. There is supranormal filling in young people due to powerful LV suction. E by A ratio in the presence of atrial fibrillation, mitral regurgitation, left bundle branch block, annular calcification, paced rhythm, MS or MVR. You can't for surely say. In this situation, other parameters becomes helpful. Let's do a TDI, measuring the annular velocity. We go to the annulus, measure the TDI. So here comes the E dash. Fine. Tissue Doppler imaging annular velocity. So basically, what does E by E dash ratio represents? It reflects the end diastolic pressure. Normally, it is less than 8 if it is greater than 15. TDI, little E dash less than 10 centimeters per second, and a septal separation of less than 7 is suggestive of diastolic dysfunction. E by E ratio of less than 8 is normal, more than 15 is associated with diastolic dysfunction. A ratio of more than 12 is sufficient to identify dystolic dysfunction in a patient on mechanical ventilation. E by E less than 8 is normal, ratio of more than associated with dysfunction in non-ventilated patients. If it is more than 12, definite to identify diastolic dysfunction patient on mechanical ventilation. I'm not going into the intricacies how to grade it, grade 1, grade 2, grade 3. You can go through the flow chart depending upon the E by A and E by E ratios. And this is stratification according to the mitral annular velocities and LA size. Fine. You can grade the diastolic dysfunctions. However, this is simple. E by A ratio, if E is greater than A, greater E dash is greater than 8, less E by E is less than 8, it's normal, impaired, pseudo-normal, restrictive. This classification is pretty easy. You can go through it. This summarizes the diastolic echophysiology, which is, again, will very clearly tell you about the normal diastolic function, mid diastolic dysfunction, moderate diastolic dysfunction, and severe. So we can grade it as grade 1 is impaired relaxation, grade 2 is pseudo-normalization, and grade 3 is restrictive. You can go through it. Coming to the right ventricular function.
Sir, you want to take a break for 2 minutes?
If it's fine with you.
We'll pause for 2 minutes. I'll have a cup of tea or something. No problem.
Yeah. Okay. I'll just leave the screen as such, but I don't know whether there's some alignment.
Like just have a cup of tea and then we can.
Yeah, I'll just come. I think it's almost 50
minutes.
Yeah, please. Thank you. I'll just join back.
So friends, we'll just pause for 20 minutes because there's a lot remaining. Kindly be patient.
Yeah. So thank you for giving me a break. Actually, we are going into the details of the things these days now, na? So it takes some time. Actually, in all, na, it's like if you divide it, it's like a basic echo, then from basic echo to the volume status, then it's LV, then LV systole, LV diastole, RV systole, RV diastole, and then the pathologies. This is how the framework goes. So let's start with the RV function now. So how does an RV differs from an LV? RV has a complex shape. LV was bullet shaped. you can take geometrical assumptions because it's like a stacked disk, LV. In RV, you cannot take any geometrical assumptions. The concentric contraction with components of longitudinal contraction are present in LV. However, RV has peristaltic longitudinal motion of annulus and inward motion of the free wall and apex. Within a single view, you can see all the parts of LV. In RV, you cannot have a single view. So measurements of longitudinal motions, and you require for oblique alignment, you require a T. So let's see the RV function. So RV, chamber and dimensions, typical apical 4-chamber view, triangular, crescent shape, diameter less than 3 centimeter, and diastolic area less than 2/3 of the end diastolic area, wall thickness about 0.5. This is how we see how the end diastole measures and how it is crescent shaped. This is how it appears in the subcostal. So this is a normal RV. RV, LV, RA, LV. Fine. You can see the dilatation in the picture 1 with the small LV. You can see the septal flattening with paradoxical motion in the third figure. You can see the hypokinesia in the second. So moderate dilatation, ratio is 0.6 to 1. If there is a severe dilatation, the ratio is greater than 1. Again, the systole and the diastole. So RV systole, you assess by TAPSE, functional area contraction FAC, S dash velocity, the T index, the hepatic venous Doppler, 2D and the 2D speckle tracking, and the 3D ejection fraction. Fine. 1, 2, 3, 4, 5, 6, 7, 8. We'll try to discuss as much as possible how to assess the RV systolic functional assessment. The important thing is TAPSE. Fine. The RV systolic functions, the 2D measurements, normally right ventricular area or the left ventricular area is less than 0.6 and the RV length is 0.6 less than the LV length. The dilatation of the RV can be graded as mild, moderate, severe. RV area upon LV area equal to 0.6, the dilatation is mild. If it is equal to 1, the dilatation is moderate. If it is greater than 1, the severe. RV dilatation severe is RV area upon LV area greater than 1. The causes of RV dilatation and dysfunction: pulmonary artery hypertension, coronary artery disease, tricuspid or pulmonary regurgitation, atrial septal defect, ventricular septal defect, dilated cardiomyopathy, which may occur due to idiopathic chemotherapy or pregnancy induced. Catch point of the slide: mild, moderate, severe, 0.6, 1, greater than 1. So this is how the normal range for the RV thickness appears. It's less than 0.5 centimeter. Fractional area change. Fine. End diastolic area minus end systolic area upon the end diastolic area. So right ventricular fractional area change correlates well with the right ventricular ejection fraction, normally greater than 32, mild dysfunction 25 to 31, moderate 18 to 24, and severe is less than 17. We are assessing the fractional area change. How do you measure fractional area change? Diastolic area minus systolic upon diastolic into 100. Then the right ventricular fractional area correlates with the ejection fraction. Normally it is greater than 32, mild dysfunction 25 to 31, moderate 18 to 24, severe less than 17. Fine. This is how it appears, the fractional area change during end systole and during end diastole. Fine. Coming to the TAPSE. The TAPSE, in the M mode, cursor of the echo is placed at the lateral annulus of the tricuspid wall, and the excursion of the annulus is measured in the systole. And TAPSE has been well correlated with the ejection fraction of the ventricle. Apical 4-chamber view, M mode, fine. Measuring the tricuspid annular excursion in the systole. If the TAPSE is greater than 20, it's a low risk. If it is less than 16 millimeters, it's a high risk. Catch point: right ventricular ejection fraction is twice into TAPSE. The normal right ventricular ejection fraction is approximately 40%. This is how you see lateral tricuspid annulus, valvular motion during systole, TAPSE of 20, ejection fraction of 40, TAPSE of 15, ejection fraction of 30, 10, 25, 10. Find tricuspid annular plane systolic excursion. I'll go back again. M mode, 4th chamber, systole, ECHO placed at lateral annulus of the tricuspid valve. Ejection fraction twice into TAPSE. Fine. TAPSE. Anatomical M mode gives a better alignment. Septal attachment of tricuspid valve is fixed. Majority of the motion is of the lateral annulus. TAPSE measures the systolic excursion. However, after pericardiotomy, the anchor for this movement is lost. Hence, the TAPSE becomes less reliable in cases of pericardiotomy. Normal is 20 to 25, less than 15 is severely depressed. Catch point, ejection fraction is twice into TAPSE. Fractional area change, normal fractional area is greater than 32. Okay, TAPSE. Coming to the myocardial performance index, the TEI index, myocardial performance index, tricuspid valve opening to the closure time minus the ejection time upon the ejection time. Fine. Normal MPI for right ventricular pulse wave Doppler, it measures is less than 0.4. For tissue Doppler, it is less than 0.55. TDI, you can measure the myocardial velocity. The TDI of the lateral tricuspid annulus correlates with the right ventricular systolic function. As value of below 9.7 centimeters suggests abnormal contractility. Coming to strain rate and speckle tracking. Strain is the measurement of myocardial fiber shortening. And strain rate is the speed of deformation. Strain rate is calculated by measuring the myocardial velocities in two regions and dividing the difference by the distance. Basically calculating the velocity gradient. Speckle tracking allows myocardial velocity measurement by tracking the B mode speckles. B mode speckles are naturally occurring acoustic markers. Longitudinal and circumferential strain are indicative of myocardial shortening. Negative waveforms occur in systole, positive waveforms occur in diastole. Steeper the strain curve, the larger is the strain rate. Impaired functions, lower strain and lower strain rate. This is how they appear. Coming to the hepatic venous flow. Fine. So normal tricuspid Doppler flow velocities, normal hepatic venous Doppler velocities. Then AR wave is negative during RA contraction, S wave, RA filling from SVC and IVC, V wave negative at the end of systole, and D wave, RA acts as a passive conduit for RV filling. AR wave, S wave, V wave, D wave. Fine. Coming to the RV diastolic dysfunction. Doppler evaluation of the trans tricuspid flow velocities. Unlike the left ventricular, it is significantly affected by respiration and larger size of tricuspid valve. Spontaneous breath augments diastolic filling by 20%. Similar to LV, E by A less than 8 and greater than 2 are abnormal. Right ventricular failure may occur due to cardiac conditions or due to extracardiac conditions. Extracardiac conditions, pulmonary embolism, COPD, ARDS, primary pulmonary hypertension, sepsis, lung transplant, post thromboendarterectomy. Cardiac conditions, RV infarction, valvular heart disease, ischemic and dilated cardiomyopathies, heart surgeries, heart transplant, post LVAD. These are the various causes of right ventricular failure. We will try to look at the conditions which we commonly encounter in our setups. Right ventricular failure rarely occurs in the setting of a normal pulmonary vascular resistance. Okay. Mechanism and targeted management in specific clinical scenarios of acute RV failure. Fine. Right ventricular infarct. Why does it occur? And how it causes. Right ventricular infarct decreases the RV contractility. Pulmonary embolism increases the right ventricular afterload. Decompensated pH increases the right ventricular afterload. ARDS increases the right ventricular afterload and decreases the RV contractility. Non-cardiac surgery, it decreases the RV contractility. Cardiac surgery increase the volume overload. And accordingly, these changes can be picked up in a echo. So what do you see? So it's a tricuspid regurgitation, IVC dilated, and oh, it's a compressible or a non-compressible? Okay, it's a DVT. Diagnosis comes at pulmonary embolism. Fine. You can see the pulmonary embolism. Fine, the jet. So, RV dysfunction in acute pulmonary embolism. Right ventricular dysfunction in echo is present in 30 to 56% of the normotensive patient with pulmonary embolism. Fine. 30-day mortality is 5.4 to 10%. Cardiogenic shock occurs in 5% of the acute cases of pulmonary embolism. Right ventricle cannot acutely overcome systolic pulmonary artery pressure of greater than 50. Conversely, acute and chronic right ventricular can tolerate significantly higher pulmonary artery pressures. RV dysfunction occurs in ARDS. How does it occur? Mechanism of ARDS induced RV dysfunction includes hypoxic, hypercarbic vasoconstriction, increased alveolar dead space, pulmonary microthrombi, and obviously a cytokine activation. So both pulmonary hypertension and RV contractile impairment are the main factors involved in RV dysfunction in ARDS. So 4 predictors of acute right ventricular dysfunction in ARDS are pneumonia-induced ARDS, PF ratio less than 50, PaCO2 greater than 48, and driving pressure of greater than 18 centimeter of water. Routine echocardiography is recommended in ARDS patient, allowing an early implementation of protective strategy that might prevent RV dysfunction. So you have to create a balance between recruitment and overinflation. RV dysfunction in MI can be complicated by, say, like RV dysfunction occurs in almost 30 to 50% patients with MI, with inferior wall ST evaluation MI. Severe hypotension and low cardiac output are present in 10% of the patients. RCA is usually the culprit vessel in RWMI, and proximal RCA occlusions are more extensive, causing RV myocardial necrosis. Acute outcome of patients with right RV myocardial infarction is primarily determined by the amount of accompanying necrosis. The catch point over here is RV dysfunction in right ventricular myocardial infarction occurs in approximately 30 to 50% of the patients. Hypotension and low cardiac output is present in 10% of the patients. This is how the various parameters will look in pulmonary artery hypertension. TAPSE, RA area, eccentricity index, fractional area change. The TAPSE measures the right ventricular longitudinal shortening and is a surrogate of systolic function. Systolic dysfunction is likely when the TAPSE is less than 17. RA area, 4-chamber view, values greater than 18 centimeters square are considered abnormal. Eccentricity is defined at anterior-posterior diameter, the green line, to the septolateral diameter, the blue line. You can see the blue line and the green line. Fine. Defined as the anterior-posterior diameter and the septolateral diameter. Normal values are less than 1.1. Images in LVLSS, the images are obtained from the RV focused apical view. Endocardial border is traced. Then the software generated automatically generates the peak systolic strains. Then coming to the fractional area changes, end diastolic area minus end diastolic and systolic area, care must be taken to trace the free wall beneath the trabeculations. Low reference value for normal RV systolic function is 35, that we already know. Echo features of pulmonary artery hypertension: right atrial enlargement, right ventricular enlargement, dilatation, D-shaped LV, right ventricular hypertrophy, sorry, pulmonary regurgitation, reduced RV outflow tract velocity, slow acceleration time, dilated IVC, pericardial effusion, dilated pulmonary arteries. Here you can see in the middle 4-chamber view, the D-shaped LV, the L fraction being reduced, RV being enlarged. You can appreciate again. So let's move on to the jugglery of the volume and the pressure overload. So let's look at some facts. Right ventricular free wall thickness is less than 5 millimeter at the end of diastole. Greater than 5 means hypertrophy. More than 1 centimeter, severe hypertrophy. So less than 5 millimeter, more than 5 millimeter, and greater than 1 centimeter. Easy assessment at the cardiac apex. Usually, left ventricle usually forms. Right ventricular is 2/3 of the left ventricular in length. Right ventricular, if it forms the apex, if your right ventricle is forming the apex, it means it has a dilated RV. And diastolic area of the right ventricular is less than 60% of the left ventricular. If between 60 to 100, mild RV dilatation. If greater than 100%, severe dilatation. Fine. Shape of the RV changes from triangular to circular when dilated. Septum becomes convex towards right ventricular. Right ventricular hypertrophy, the center of mass shifts and interventricular septum is flattened. If RV mass is greater than the LV, the septum bulges into the left, paradoxical. If right ventricular systolic pressures can be estimated as RAP plus TR Vmax. Coming to cardiac tamponade. So what will be our echocardiographic features? There will be large effusion with a swinging heart. There will be diastolic collapse of the right atrium. Duration of the diastolic collapse taken as a ratio on the cardiac cycle length is greater than 0.34. There will be respiratory changes in the mitral valve velocity and the tricuspid velocity. Inferior vena cava plethora. Dilatation of greater than 20 millimeter. Let's see. How does the chamber collapse occurs and how do you pick it up on the echo? Let's go a little slow over here. The lower pressure cardiac chambers are atria. So therefore, they are affected before the higher pressure cardiac chambers, the ventricles. The compressive effect is more likely to be seen in the phase of cardiac cycle when the filling pressure within the cavity is lower, as occurs during systole for the atria and during diastole for the ventricles. So what happens? Right atrial chamber collapses. Right atrial chamber collapse begins first in the late diastole. And this precedes commonly the typical clinical signs. It is sensitive but not specific of cardiac tamponade. However, the specificity of the sign improves if the duration of the right atrial collapse exceeds 30% of the cardiac cycle. Clear? Low pressure chambers kaun se hain? Atria. High pressure chambers are ventricles. Compressive effects are seen during when the filling pressures are low. Occurs during systole in atria, diastole in ventricle, right chamber collapse of the atria in the late diastole, precedes the clinical signs. Sensitive of tamponade, not specific. However, if the duration of the right atrial collapse exceeds 30% of the cardiac cycle, it's a specific sign to say there is a cardiac tamponade. So we call it as an inversion, right ventricular chamber collapse. Inversion occurs typically in early diastole when the intracavitary right ventricular pressure upon volume is at nadir. As in right atrial wall collapse, the right ventricular wall inversion will extend further into diastole, longer duration as hemodynamics of the tamponade worsens. This echo finding is seen in the parasternal long axis view with dimpling of the right ventricular outflow tract into the anterior wall. Then what happens? The left atrial and the left ventricular chamber compression occurs exclusively described to the loculated collections which occur during the cardiac surgery. Circumferential pericardial effusion may happen leading to ventricular diastolic compressions reported in setting of severe pulmonary hypertension. What happens if there is a pleural effusion with a pericardial effusion? Large left pleural effusion occasionally has been described causing tamponade with echo signs such as right ventricular diastolic collapse. In this situation, pericardial effusion is often present and can be difficult to differentiate. Clinical experience favors first draining of the more accessible pleural fluid and then reassessing both clinically and echocardiography. Sepsis. So what happens in sepsis? There is decreased cardiac output. There is LV dysfunction. Ejection fraction decreases below 45. S- wave is less than 7.5. And there is global longitudinal strain less than 20%. RV dysfunction, RV upon LV dilatation occurs greater than 0.6. TAPC is less than 16. RV fractional area change is less than 35. What happens to the LV diastole? LV diastolic lateral E valve is less than 7 per second. Septal is less than 10. E by E ratio is greater than 13 centimeter per second. So, sepsis or septic cardiomyopathy, decreased cardiac output, RV dysfunction, LV dysfunction, and LV diastolic dysfunction. Fine. This is a very interesting thing. Echocardiography in the management of sepsis is not all black and white. I just took this study because just see, in 2018, a group of authors examined the association between the use of transthoracic echo and mortality in patients with sepsis. Fine. And they found out having an echocardiogram during an ICU stay for sepsis was associated with a decreased risk of death. 1 year later, a similar study using a similar data set found a similar association but using a different statistical approach. Fine. What they say is no means new, but bears repeating nonetheless. The crux point over here is casual inference from an observational data is not an exact science. These are all observational data, and any inference casually derived from them cannot be an exact science. Its output must be interpreted as one might set the gain when doing an ultrasound of the heart to see and appreciate all the important shades of gray. Fine. So these are all observational data studies. Chalo, let's move out. That was to take a little break. Echo assessment during hypotension. What happens during hypotension? So if you have a severe LV dysfunction, see the echographic parameter LV systolic function and the global LV dysfunction. You need to start inotrope or you need to reassess. If there is hypovolemia, you ought to look at the LV cavity size. Then again, give fluid therapy and reassess. Embolism we have already seen. Ischemia we have already seen. If there is tamponade, we have already seen. Then mitral regurgitation, aortic regurgitation, and aortic stenosis. I have not taken here valves into consideration. Fine. Again, valves, assessment of the valves, regurgitation and stenosis would have added another 30-40 slides that can be taken separately, and I think it will be better if a cardiac intensivist takes it. Only the valves and the bypass and the other valvular surgeries they carried out and the complications that occur thereafter. So hypotension shock. You can visually see the LV-RV size and the function. You can assess the stroke volume. And LVOT VTI less than 18 centimeter, greater than or equal to 18 centimeter. If it is less, so we have an obstructive shock. If it is greater than 18, we have a vasoplegic shock. Then you need to assess if it's an obstructive shock, you look at the LV pressures. If they are elevated, it's a cardiogenic shock. If it is normal, then check the end-diastolic area. Reduced, it is hypovolemic. If it is normal, it's a vasoplegic shock. It's a basic flow chart to use echo and assess various types of shock like obstructive shock, vasoplegic shock, hypovolemic shock, and cardiogenic shock. Again, this is a detailed critical care echocardiography driven algorithm in which you can differentiate, you use cardiac echo along with lung ultrasound and extravascular lung volume to find out the type of a shock, which can be vasodilatory, cardiogenic, obstructed, hypovolemic, or mixed shock. This utilizes echo with lung ultrasound and extravascular lung volume. So this is simple. Let's look how to use echo in an acute respiratory failure. Fine. 2D or a Doppler, check for volume responsiveness, hypovolemia, and obstructive etiology. No, altered RV function. Okay, yes. If it is yes, look out for systolic heart failure, low ejection fraction, congestive heart failure, look out for obstruction, LVOT. If there is not, look out for valvular dysfunction. If there is no valvular dysfunction, look out for diastolic dysfunction. No, then look out for volume overload. Similarly, if there is altered RV function, look at RV afterload, PVR is too high, embolism, ventilatory settings, atelectasis, pleural pathologies. If not, then look at whether the preload is too high. This is how an algorithmic approach to respiratory failure can be taken while using an echo. Hypoxemia. Fine. So how will our echo help in assessing hypoxemia? So we are considering over here pulmonary edema, intracardiac shunt, pulmonary embolism, pneumonia, atelectasis, or pneumothorax. So let's look. Visualization, eyeballing, RV, LV, size and function. Fine. We look at the assessment of the LV filling pressures, normal pressures. Okay. Normal pressures, we assess the RV and the pulmonary artery. If they are abnormal, it is pulmonary embolism. If it's normal, assess the intracardiac shunt. Normal, then look at lung ultrasound. If the LV filling pressures are elevated, it's hydrostatic pulmonary edema. So you can see these black boxes, echo signs of normal LV filling pressures, and then echo signs of increased LV filling pressures. You can just go through it. We have already discussed it. Cheops. I found it interesting, therefore I placed it. Cheops, bundle management of left ventricular diastolic dysfunction. It's an expert opinion, not an RCT, not a meta-analysis. So if you have a patient with left ventricular diastolic dysfunction, how to go about it? Do a chest ultrasound, look at the hemodynamics, look at the heart rate, look what vasoactive vasopressors are we using. We should optimize the PEEP, look at the pulmonary circulation at the right ventricular and stabilize, and if required, remove the fluid. So cheops, chest, hemodynamics, optimize PEEP, and stabilization and fluid removal. Fine, cheops. Cheops bundle management, chest ultrasound, hemodynamics, optimizing of PEEP, and stabilization of fluid management. This is a very comprehensive way to manage a left ventricular diastolic dysfunction, and one should try to inculcate it into our clinical practice. VPO, weaning induced pulmonary edema. Fine. Cardiovascular failing and weaning. Often we encounter this in our practice. We have to identify the patient who are at high risk. Screen the patients. Which patients are at high risk? Cardiomyopathies, LV systolic function. We have to look at the atrial size. We have to see at the E by E ratio and the deceleration times. Look at the pulmonary artery pressures and the maximum velocity. Characterize the baseline, and baseline will help you as a reference. Fine. Give an SBT, patient passes or fails. So how to identify weaning induced pulmonary edema and its mechanism? It may be depicted as elevated or increased LV filling pressures compared to the baseline. There will be new onset or worsened LV dysfunction, new onset or extension of LV regional wall motion abnormalities, absence or even increase of decreased LV stroke volume, increase in E by A or E by E ratio. There will be worsening of mitral regurgitation and worsening of pulmonary artery hypertension. We should document it, and then found whatever abnormalities are found at step 4, they are taken to be corrected or improved before scheduling a new SPT. feel. The feel is coming because we are coming to the end. Will almost be, this is I think last or second last slide. Focused evaluation by sonography in life support. Field protocol is used during CPR. Catch point, 10-second countdown pulse check. A focused point of care examination can be performed by a designated member of the resuscitation team while others are performing a CPR and ACLS. Subxiphoid or a subcostal window is the best view to perform a focus during cardiac arrest. Short differential diagnostic list. You can easily identify on an echo hypovolemia, bilateral dysfunction, right heart stain, embolism, and cardiac tamponade. So focused evaluation sonography in life support. Fine. There is a dedicated person who does this. Window is subcostal window. We look at the potentially treatable causes such as hypovolemia, biventricular dysfunctions, strain, embolism, cardiac tamponade. That's it. Again, the same last slide. There is huge to grasp upon. We might fail to understand it in the first attempt. We must try to learn it. And then eventually we might succeed. Thank you, Dr. Tapesh. It has been a long one.
Yes, yes. Thank you, sir. So please stop the share screen.
Okay, just a second.
Okay. So, friends, I think that was a very comprehensive talk. And now we have two videos on echocardiography, I think, which covers everything. And if you go through these videos, you'll be able to actually, I think, learn. Of course, one has to practice, but they cover all the aspects that one needs. I think most of the things are covered now in video 1 and video 2. And basic stuff is there in video 1, and this is much more detailed. So with this, I think if you go through these two and practice, you'll be able to do the echo as required for an intensivist. And of course, then there are other things in focus like critical care nephrology is coming up and VEXUS. So all those things are also there, transcranial Doppler. So subsequently, we will try to cover those things. If you have any questions, anybody, please feel free to ask. And what comments or what advice would you like to give, Dr. Khanna, to beginners, beginning intensivists? How should they approach this aspect of learning and mastering echocardiography?
So the thing is, listening to the webinars, reading the books, unless and until we put it out in practice to the patients, now it is very difficult. See, the first slide of mine is the whole of the parameters and whole of the things that we have learned in the cardiac patients, which is quite normal. But quite in the sense you have very fixed parameters. But when these things happen in a critical care patient, with patient lying on an ICU bed, you can't have appropriate views because you can't position the patient so well. So practicing will make it eventually easy.
Right. And sir, what about patients who are on the ventilator and with high inflation pressures? What kind of adaptability is required for those patients?
See, accurate measurements become very difficult with that thing because you cannot position it. Getting a good view itself is very difficult. It's the practice, I think, will eventually help us a lot.
All right. So I think, friends, do the practice, and practice makes a man perfect. And I think go through video 1 first and then go through this video 2.
Yeah, I will suggest the same thing. There is no point in going through the video second straight away. 1 and then second, then it will help a lot.
So thank you, Dr. Khanna, sir. Thank you very much. Exhaustive lecture, and you must be tired. Please take some rest now. Really, thank you so much. Thank you.
Thank you, Tapesh.
Forward to another session after some time on probably critical care nephrology focus, sir.
Yeah, sure.
Thank you.